Our complete team follows well-defined processes and protocols that are designed keeping our patients at the center always. The international standards, best practices and learnings are always kept in mind while doing so. We continuously measure our outcomes, audit our systems, and also train our people to deliver high-quality, safe care. Before any medication, blood transfusion, or blood sample collection, our staff will verify your identity by checking the ID band on your wrist. This ensures that you receive the right treatment and prevents any errors. We believe in open communication. Your doctor and the healthcare team will discuss your diagnosis, test results, care plan, and treatment options with you. If you have concerns, please ask for a family meeting. Our staff will provide detailed information about your medications, including why they are being given, their timings, effects, any side effects, and important instructions you need to follow. Hand hygiene is crucial in infection prevention. Our staff will always sanitize their hands before they examine you, ensuring a safe and clean environment. Please ask your healthcare provider if they have washed their hands before touching you. When transported on a wheelchair or stretcher, safety belts will always be used. Your safety is important to us, and we take precautions to prevent accidents. When on the bed, side rails will always be raised and the bed height will be adjusted to minimize the risk of falls. It is your responsibility also to please call if you would like to move out of your bed. Before any procedure or surgery, your doctor will involve you and your family in the decision-making process. Additionally, the surgery site will be marked by your doctor to ensure accuracy. Your doctor will explain the procedure or surgery to you, discussing all the relevant details. Your written consent will be obtained before any procedure or surgery. We want you to feel comfortable and safe during your stay. We will orient you to your room, including the call bell, washroom facilities, or any other necessary instructions. We will also explain the nearest fire exit and provide layout information for your safety. When you need assistance, we are here for you. Our staff will respond promptly to your call bell to address your needs and ensure your comfort. We respect your privacy and confidentiality. Your medical records and clinical information will be managed securely during your hospitalization and even after your discharge. At Apollo Hospitals, we are committed to providing you with the highest level of quality and patient safety. We need your feedback to help us improve our systems and ensure your satisfaction. Thank you for choosing us for your healthcare needs. Please let us know how we can serve you better to make your care safer. You may receive a feedback form on discharge to rate us on our quality and safety practices. We would like to request you to kindly respond to the same. We wish you a healthy life ahead.
Thank you. We actually have started using this video. We have made it based on patient safety standards that we follow at Apollo. Let me give you a very quick brief or introduction about International Patient Safety Conference. IPSC is an endeavor that brings together healthcare professionals from different disciplines and sectors to discuss and deliberate on every aspect of patient safety. The focus on this 10th conference today is on lessons from the pandemic and the way ahead, and hardwiring patient safety in our institutions. We will cover topics such as infection prevention control, medication safety, patient engagement, empowerment, digital health innovation, quality improvement, accreditation, leadership, culture change, among many others. Before we begin our today's session, let us watch a short launch video on 10th International Patient Safety Conference 2023. Thank you. That was a wonderful video that actually highlighted the robust patient safety practices that could be used as best practices across. Before we start with the first session, I would also like to request all the delegates, to just type in their questions if they have any, and we would like to take those questions by the end of the sessions and as the time proceeds. The first session for the day on lessons from COVID era and road ahead is going to be moderated by Professor Dr. Anupam Sibal, Group Medical Director, Apollo Hospitals Group. Dr. Sibal is a pediatric gastroenterologist and a hepatologist who has been overseeing the clinical operations and quality standards of Apollo Group since 2005. He's also an active member of various national and international bodies related to healthcare quality and accreditation. Our first session today is a keynote address by a very eminent speaker, Sir Liam Donaldson, who doesn't actually need an introduction. Dr. Sibal, may I please request you to take this forward?
Namaste. Good morning to our friends in the East Coast. It's 9:30 in the morning. Good afternoon to our friends from England. It's 2:30 in the afternoon. It's 3:30 in the afternoon in Geneva. Good afternoon. And in Singapore, it's 9:30 p.m., getting to bedtime. And in India, it's a few minutes past 7. We are delighted to welcome you all to this session as part of the International Health Dialogues International Patient Safety Congress. And who can we have who's a bigger luminary than Sir Liam Donaldson to deliver the keynote. Sir Liam served as the Chief Medical Officer for England for 12 years from 1998 to 2010. He was in 2010 appointed as the chairman of the International Monitoring Board overseeing polio eradication. He served as the Chancellor of the Newcastle University for 2 terms. He's recognized as an international champion of patient safety and public health. He was the foundation chair for the World Health Organization World Alliance for Patient Safety, which was launched nearly 20 years ago, 2004. He's a past vice chairman of the World Health Organization Executive Board. And in 2002, in the New Year's Honors List, Sir Liam was awarded a knighthood in recognition of his achievements in healthcare. We are delighted to welcome you, Sir Liam. It's always a great learning experience interacting with you, and many of us have had the good fortune of spending time with you over the years. So over to you, Sir Liam, for your keynote.
Thank you very much, Dr. Sibal, and hello, everybody. COVID-19 was a new intruder in the patient safety landscape. The story of the pandemic has, of course, been very well documented. Its mode of transmission, its clinical manifestations, its short and long-term effects, how immunity is acquired and sustained, and the epidemiological trajectory through populations is now pretty clear. It's been intensively studied by the world scientists, and a remarkably rich tapestry of knowledge has been accumulated, and of course, it's still growing. But COVID-19 is primarily an infectious disease, as we all know, but its potential seriousness as a cause of harm and death has meant that the virus has been intimately related to many different aspects of healthcare processes in hospitals, in care homes, in the community, and in populations at large. It's made us think more seriously of the infections which are called pandemic, which are said to have pandemic potential, not just how they kill people, but how they also kill economies and how they change people's lives permanently. When the pandemic struck, there was an early debate amongst members of the patient safety practice community about its relationship to their work. Over the years, the WHO patient safety teams built a very extensive global network of patient safety leaders, experts, advocates, policymakers, and practitioners. So when COVID-19 began to surge in their countries, these individuals began to interpret and share their experience of the pandemic's impact on patient safety and the ways that they were using to try and reduce potential harm. So in this short presentation, I want to highlight some of the key themes that emerge from an analysis of the information that was shared with us. And my analysis and feedback from the field is a companion to a formal published document, a WHO scientific brief called The Implications of COVID-19 Pandemic for Patient Safety. Health systems suffered a surprise attack, and primarily it tested the resilience of those health systems. And a key characteristic of health systems is how resilient they are. There are many formal definitions of resilience, but the one I like most is very informal, and it embodies the idea that when confronted by a serious threat to their normal functioning, organizations will bend, not break. They will bounce back, and they'll adapt and grow to successfully meet the new challenges or the new world created by the crisis. So resilience is a big and fundamental concept in patient safety. Indeed, it applies to all safety critical industries. It's linked closely to the idea of high reliability organizations, those that anticipate, prevent, and reduce the impact of risks and threats to their safe operations. The most obvious manifestation of the interrelationship between COVID-19 and patient safety is that the pressures and urgent demands on health systems around the world tested them and found serious gaps in their resilience. This meant that many health systems and health facilities were functioning in ways that inadvertently generated risks to patients and health workers, and inevitably led to higher levels of avoidable harm. And despite the good work by policymakers, leaders, and health workers over the last decade, the attack by COVID-19 found serious gaps in patient safety defenses. Those working in patient safety programs around the world saw many consequences of these gaps being played out in the settings in which they were based. One of the biggest, of course, was the amplification of the impact of the virus itself. Failure over the years to develop world-class infection prevention and control policies and practices at health facility level produced many care environments where the infection spread too readily, leading to unsafe environments in which patients and health workers' lives were put at risk. In many parts of the world, long-term care settings with frail elderly residents suffered high fatalities. And a further factor in the risks of this vulnerable group related to transfer policies between hospital, care home, and community. In the fast-moving pandemic context, decisions, for example, to test before transferring were not always carefully thought through, nor were they dictated by capacity problems. Yet it's well established in patient safety experience that transitions of care of any kind inherently carry much higher risks of error and avoidable harm. So these weaknesses in health system resilience to limit the spread of infection within facilities and in movements of patients across care sectors were compounded by insufficient supplies of personal protective equipment for staff and serious shortages of testing capacity and capability. Another major shortfall in health system resilience has been the failure to maintain continuity of services for patients with non-COVID conditions. And this, of course, has been intensively discussed and evaluated since the early stages of the pandemic. In addition to the serious reductions in access, diagnosis, and treatment that had been available before the pandemic, new needs and demands for care surged as a result of the impact of COVID-19 on people's lives. This additional cohort included many adults, children, and adolescents with major mental health needs. The health system context in low and middle income countries is, of course, very different from those in high income countries, and it's also very diverse. So in settings with poor infrastructure, shortages of skilled staff and equipment, and limitations in access to primary care and specialist services, pre-pandemic needs of people with serious non-communicable diseases, as well as those suffering from major endemic communicable diseases, were not being fully met. The additional harm caused then by the pandemic-related loss of services created a form of double jeopardy for those communities in low-income and poor resource settings. These sources of avoidable harm are partly created by the closure of facilities and services to reduce the spread of the pandemic virus, but they're also due to the repurposing of the public health workforce as its staff were redeployed to fight COVID-19 and subsequently then to plan and deliver the vaccine program. And the point repeatedly made in feedback from the field is that in many countries, there is only one public health workforce. So if staff are moved to dealing with the emergency, then they're not available to provide continuity of essential health services. Over the last 2 decades, the process of healthcare that can lead to avoidable harm have been very well established. The role of poorly designed or executed systems and practice make it much easier for someone to make an error or to enhance the impact of that error, and make it much more difficult to prevent errors. And this has become the predominant paradigm for understanding avoidable harm. But under pressure, those processes of care and systems of practice become much more prone to error and dysfunction. And this is what happened in the COVID-19 pandemic. Pandemic planning and preparedness activities prior to 2020 gave little attention to patient safety beyond the dimension of infection prevention and control. But if anyone had thought about the implications of a pandemic for patient safety, 2 conclusions would have been obvious. First, existing patient safety incidents would continue to occur, and some would become more likely because of the pressurized staff and clinical environments created by a health emergency. And second, new kinds of patient safety incident would emerge. And this is what exactly came to pass. And it was confirmed by the observations and experience of the patient safety community. Pre-pandemic medication error and avoidable harm from medication make up a relatively large high proportion of incidents reported. But in the pandemic situation, medication situations became even higher risk and exacerbated by the pandemic. There was also widespread feedback that rates of patient safety incident reporting went down, perhaps at the very time that they were needed most. But it became pretty clear early on in the pandemic that a new normal for patients and families was emerging. Doors were closed, service pathways were blocked, and care continuity was fractured. As health systems around the world struggled to provide care and support for the large numbers of acutely ill patients experiencing the effects of the new pandemic virus, the high volume, high pressure context for the delivery of services, together with the need to reduce transmission, created a new operational reality. Normal patterns of care for patients were immediately disrupted. And this took its toll on patients and families. As the pandemic unfolded, patients and family who've been part of the global and national patient safety programs have pointed out that their role in supporting care needs and service provision was severely disrupted. But they also expressed their concern that patient safety concepts and ways of thinking were marginalized in the intensity of the acute response. They asked why, given that patients and families were so heavily impacted by the disease, were they not part of all decisions at all system levels, even during the crisis? Moreover, in such a novel situation, to be effective, partners, patients, and families need guidance and support, and sometimes equipment. Although families were clearly positioned as partners in care and potential partners in care, they weren't being fully utilized. They were not there to ensure safe care, and ethical decisions were being taken. For example, consent for those unable to give their own consent at the end of life. They also normally play a key role in providing continuity of care, and they weren't able to do that either. So very strong views emerged amongst the patient and family community involved normally in patient safety and in day-to-day care. Very strong views that the visitation policies and practices put in place as part of facility-based infection prevention and control members severely disadvantaged them, and in some cases led to their loved ones dying alone, where their family was unable to intervene and provide the support required. Now, this is a short presentation. There's a lot more I could have said about the relationship between COVID-19 and patient safety, but I think I've covered the main points. And I want to come back now with a central message by way of conclusion. And my central message is one of the need for deep learning from what happened. The lessons of COVID-19 must drive safer and more resilient health systems for the future. And here are 7 points that to leave you with that I think are essential in planning for the future. Firstly, a health system that becomes all-consumed by the acute care needs of the emergency itself is not demonstrating resilience. It's breaking and not bending. Remember the old BBC radio announcement: normal service will be resumed as soon as possible. Well, the planning must ensure that normal service is still possible. True resilience is bending and not breaking. Number 2, high quality infection control and prevention practices in all health facilities are an absolute must. They have to be there in advance and not backfilled. Otherwise, the impact of the harm will be amplified, and failing to address this is a serious own goal for health systems. Number 3, think particularly of the protection of high-risk populations. A priority has to be the safety of elderly people in nursing homes and other long-term care settings. And that's been one of the most prominent features of comments made about the COVID-19 pandemic and patient safety. Number 4, remember that patients and families are our partners in planning, designing, and delivering care. We need them most in a prolonged emergency, and they were too often kept out because the pandemic paradigm was a technical one of communicable disease control, and it was rigidly adhered to as loved ones died and suffered alone. Point number 5, learning and improvement is not a leisurely activity to be pursued on study days. It should be part of the everyday work of a high reliability organization. If it was abandoned during the pandemic, work out why. Try to see how it might be integrated into the health emergency response of the future. Number 6, let the COVID-19 experience be the impetus to focus on our healthcare workers. Too many died or were harmed during the pandemic. We should plan so that they have a high level of protection in the future, but it should also be a springboard to take a longer look at their health and well-being, their education and training, their aspirations, and their hopes to build interesting and fulfilling careers. And then finally, I've heard a lot about how COVID-19 changed the way that services were delivered around the world. People say that they worked much closer with others. They saw silos broken down. They described these changes as transformative. They called it COVID's silver lining. What's been much less clear is how this new way of working will be imported into other areas of care. How will it transform the care of diabetics? How will it dramatically reduce suicide rates amongst young adults? How will it remove the fragmentation of care for the frail elderly or those living with disability? We need to be convinced and try hard to see through the fog of the status quo if we're to realize a COVID dividend for future, safer, higher quality care. Thank you.
Thank you. Thank you so much, Sir Liam. A brilliant presentation as always, in-depth analysis of the learnings. I love the term COVID dividend. In India, we keep talking about demographic dividends. So you introduced us to a new term that I think we shall all think about, and you'd be really delighted in the Delhi declaration that came out a few days ago as part of our G20. The word resilience, the word equitable came up multiple times in reference to healthcare. And you mentioned those 7 points. The declaration really talks about learning from COVID while we prepare for COVID, but also what you referred to as the BBC announcement that routine work cannot be pushed aside. And if the pandemic, what the pandemic did this time, another pandemic could do the next time, then we wouldn't really have learned the lessons. And clearly there is an opportunity for deep learning so that, we are better prepared for the future. Deeply appreciate you taking time out, Sir Liam. We know that you stepped out of a meeting and you have to get back into one. So thanks ever so much, and over to you, Gaurav.
Thank you so much, Sir Liam and Dr. Sibyl, for that wonderful session. Here, I would also like to thank our audience. We had almost 1,250 registrations for this event. So we have people joined here, as well as we are streaming live on YouTube, where we have delegates who have joined this today's evening conference. Moving forward for our next session is a very special address by a very special person. I would like to invite Dr. Sangeeta Reddy, Joint Managing Director of Apollo Hospitals Group, to share her thoughts with us. Dr. Reddy has been instrumental in shaping the healthcare landscape of India and beyond. She's also a passionate advocate for patient safety and quality improvement. Would be very happy and request Dr. Sangeeta Reddy to please deliver her special address.
And Gaurav, before we get Dr. Sangeeta to address us, I just wanted to add one point, that her role over the last 12 months in G20 as chair of Empower, something that has received special mention in the declaration, really gives us a sense of pride of having someone from healthcare lead an area which is beyond healthcare, but so important. Ms. Sangeeta.
So, good evening, good morning to some from other parts of the world, and especially namaste. It is a great pleasure to be with you today. It's a special day on many counts for us as Apollo celebrates our 40th anniversary. But I think the world over, it is also just yesterday that all of us celebrated or noted the importance of World Patient Safety Day. And the WHO had really rolled out an ambitious Global Patient Safety Plan 2020 to 2030. And the ideology was to enhance patient safety. And as part of this broad focus on patient safety, I'm extremely happy that our team has, as part of the 14th Patient Safety Conference that they've conducted, they chose this opportunity of our 40th anniversary to say, let us on this special day do something of a deep meaning and a great importance. So I want to thank our team, especially Dr. Anupam Sibyl, Dr. Gaurav, and Dr. Hari Prasad. Thank you all. But also a very special thanks to our extremely distinguished speakers. Sir Liam Donaldson, your background is so well known and precedes you, and the depth and the strength of the points which you made during your presentation have really enlightened us further. Dr. Neelam Dhingra, a good friend and a well-respected member of the WHO. Dr. Jonathan Perlin, another friend, and the CEO of the Joint Commission. It's a pleasure that he can be with us as well. Dr. Kedar Mate from IHI and Dr. Atul Koshad, NABH, which is the standards for India. all of you distinguished speakers, thank you for joining us today for later the panel discussion, which I'm sure will be very enlightening, and really for being a part of this. I'm not going to, lecture to the choir. You know these points as well as I do. The fact that, 1 out of 10 patients is harmed by something which happens within healthcare, within our own hands. Over 3 million deaths occur because of unsafe care. And in low to middle income countries, as many as 4 out of 100 people die from some kind of unsafe care. All this is very well known to you. I'm going to pull out that one kernel that I found in Dr. Liam's lecture, and that is, over the last decade, the methodologies of process, patient care, and infrastructure have been well documented and well proved of what is a safe healthcare environment. And because these things are known to us, it is critical that we ensure that we do not cause any harm. And this is, the tremendous adage of all doctors itself, that at the very least do no harm. I think focusing on the many initiatives that can be done, whether it's accreditation by a national or an international body, to set the standards, monitor the quality and the safety, keep up the training of the healthcare workers and everybody in the team, and bring that sense of togetherness and team, implement the various protocols, whether it's medication safety or surgical safety. Each one of these has a deep meaning and must be meticulously practiced because it could save a life. Now, adoption of cutting-edge technology and innovation is going to become a whole new paradigm. And I don't think any conversation that we're having these days is complete without a mention of artificial intelligence, what we call assisted intelligence, because it will really help doctors. It will assist doctors and healthcare workers. So whether it is, algorithms sitting behind all your CTs and X-rays to give, the initial diagnosis, to speed up. Imagine if we had a detection of early bleeds, which is, an algorithm that we wrote at Apollo. So the detection of early bleed is in the CT scan. Your technician is doing the CT scan at 2 a.m. You're going to get a doctor's consult on top of it, but it may take time. But if within the first 3 minutes of beginning the scan, the technician has the AI applied and it says possible bleed in the brain, the speed at which you will get your radiologist to see it, whether he's seeing it from home because you have that access, or here, whether you quickly get your neurosurgeon, open up your theaters, or your theater's already open, but you begin the process and you reduce the cycle time for going into surgery. This is, it sounds very basic, but one step like this can make a significant difference to the time and the life and the suffering of that individual and of that family. Across the spectrum, there are many, many, many aspects of artificial intelligence, digital health, telemedicine, telementored surgery, all kinds of technology. So my big call to all of you would be to please adopt technology, evangelize technology wherever you find it has a proven capability to make a difference in a patient's life. The next critical one I would like to highlight, and again, it was mentioned by Professor Liam, is engagement of patients and their families in the care and the decision-making and the empowerment, whether it's in the way you give them the information, the ability to sit next to a patient during ICU, whether it's in direct care or in the softer element of stimulating a patient and giving them a reason to fight for their life. Please involve the families as much as you can. I understand that sometimes it's a hindrance. I understand that they distract doctors and patients from what they believe is their primary core. But please work in the time, the process, and the ability to involve families. That is one of the most powerful things that we can do. And finally, I believe that forums like this, participating in national and global forums and partnerships to advocate and influence policy reforms, best practices, methodologies, to share anything that you believe has helped in your facility. Share that with someone else, even if you're putting it on our chat box today. Whether you're part of this forum, our patient safety commitment is very strong and very deep. I, of course, invite all of you to our conference, which is going to be in February, but more importantly, to keep up the dialogue, to keep up the evangelizing of this powerful aspect. These are things that I believe in very strongly. I want to end by really wishing all of you the very best, because I know that the work that you do is critical. The role that you play, the challenges that you have, the continuous transference of the healthcare worker, the safety standards, the new technology. So much is changing, and these are everyday challenges. Yet today is Vinayaka Chaturthi, or the religious festival, where we pray to the Lord Ganesh to remove obstacles. But can we make these obstacles into opportunities and really find a way to do something? Because with the combination of technology as we know it, connectivity as we know it, awareness level, the entire science and medicine coming together, never at any time in history has the world been so capable of taking care of human life as it is today. What we did in COVID was a great lesson, from vaccine to saving lives to new processes. So I would end by urging every single one of you to please seize the opportunity to create a world of health equity, where every individual on this planet has the right to live a healthy, good life. And I thank you all for the great service that you do. I appreciate your commitment and your constant commitment to learning as well as to patient services. And once again, my genuine thanks to the Apollo team for spending their holiday evening and their Vinayaka Chaturthi dedicated to patient safety, because it is really at the heart of everything that we believe is sacred. All the best to all of you and to your families. Take care, and thank you for this opportunity to share a few words. Namaste.
Thank you so much, ma'am, for your inspiring words. We were indeed honored to have you with us today. And I think lots of important points that you shared with everyone will really help us to move forward and doing much more in terms of patient safety. So thank you once again, ma'am. Moving ahead, for the last session of the day, I would like to request Professor Anupam Sibal to kindly moderate this session as well. The next session is a panel discussion on hardwiring patient safety. In this session, we will hear from 4 eminent panelists who will share their views and experiences on how to embed patient safety into the DNA of healthcare, organizations, and systems. They'll also discuss the challenges and opportunities in this regard. I would request Dr. Sibal to please take this forward.
Thank you. Thank you very much, Gaurav. Thank you very much, Dr. Sangeeta Reddy, for your inspiring words. As always, for everyone's benefit, she just landed a few minutes ago from Chennai into Hyderabad, and there she was saying and giving us the message in a manner that only she can. And of course, AI has got everyone excited. And this year, the World Health Organization's theme for patient safety is engaging patients for patient safety. So that really resonated very well. Thank you so much. We move on to our panel discussion. We have 4 eminent panelists, experts from across the globe. It's a privilege to introduce my dear friend, Dr. Atul Mohan Kochar, who served as the president of the Society for Pediatric Dermatology. He's a very distinguished dermatologist. He is at present the Chief Executive Officer of the National Accreditation Board for Hospitals and Healthcare Providers, very well known as NABH. That is the body responsible for accreditation of healthcare facilities in India. He has more than 70 publications, 4 books to his credit, and under his leadership, NABH has extensively enhanced its footprint, not just in India, but also in 8 countries. A privilege again to invite a very dear friend, a colleague, someone we respect a lot, Dr. Neelam Dhingra, who's the unit head, the World Health Organization Patient Safety Flagship Initiative, a decade of patient safety 2020 to 2030. and risk management, service delivery, and safety at the World Health Organization headquarters in Geneva. Neelam's been leading the World Health Organization's efforts at providing strategic leadership on patient safety and risk management. She's been doing this for a very long time, and one of the reasons that we today have a global patient safety program, we have a patient safety day that is recognized across the world, is because of Neelam's efforts over the years. She's been with the World Health Organization since 2000. A privilege again to invite a dear friend, Kedar Mate, who's President and Chief Executive Officer at the Institute for Healthcare Improvement. Kedar's work in this space has global recognition. He's in an earlier life worked at Partners in Health. He's worked at the WHO and served as the Chief Innovation and Education Officer for the Institute of Healthcare Improvement. His talks, his sessions are very popular, and we are privileged to have Kedar here. Multiple honors have come his way. He's also a member of the Aspen Global Leadership Network. And then, of course, we have someone who's so well known globally, Dr. Jonathan Perlin, who's the President and CEO of the Joint Commission Enterprise. Before moving on to the Joint Commission, as President, Clinical Operations, and as the Chief Medical Officer of HCA Healthcare, the largest healthcare organization in the private sector in the world, John led clinicians, data scientists, and researchers in developing a learning health system model for improving care at the system's 189 hospitals and 2,200 other locations. John comes with a lot of experience. He's served as the Undersecretary for Health in the U.S. Department of Veteran Affairs. And ever since he's come to the Joint Commission, he's embarked on a bold new vision to meet the expectations of patients, healthcare professionals, and providers. So as you can see, a very powerful panel. And what we're going to be doing is really asking each of the panelists the same question. Please share your perspective on how to hardwire patient safety. I'm going to request Dr. Jonathan Perlin to start off, please. Dr. Perlin.
Namaste. It is a delight and privilege to be with you, and we thank Apollo for convening the 10th annual Patient Safety Conclave. Thank you, Dr. Sabal and Dr. Reddy, for your leadership. In the next 6 minutes or so, I wanted to bring a sort of balanced approach to thinking about safety. And I'm entitling my comments Hardwire, Softwire, Rewire, and Address the Hot Wire. When I step back and think about what does safe care look like, or quality care, after years of thinking about it, it comes down to this. It's care that has the attributes of safety, effectiveness, efficiency, equity, and compassion, but can be delivered without the need for an advocate. And that gets to the first topic. How do we hardwire for safety? Well, this is where I think technology is so tremendously important. I'm actually coming to you today from a meeting at the National Academy of Medicine, formerly the Institute of Medicine. And for 20 years, we've been working on this concept of learning healthcare, which really is as simple as this. How do we create and tap into the collective memory of all the healthcare that's delivered? Data are created as an inevitable byproduct of care, and they serve a transaction. They tell you what a patient's CBC is or what their sodium level is. But the data in the aggregate are a collective memory that help us uncover discovery, learn, make improvement. And one can imagine a future where some experiments need not actually be done because the answers already reside in that collective memory. And we can answer in silico what would actually take years to figure out in vivo. So instantiating capacity to have a collective memory and tapping into it, into our workflow with technologies is extraordinarily important. It requires bringing those data together, requires commitment to continuous learning. It then can provide decision support and the capacity to learn from that collective experience. In my past life and working in a large health system, we answered a question about how to reduce infections, MRSA, MRSA in particular. Did a study, cluster randomized across 43 hospitals. The study was completed in 43 hospitals in 18 months. It would have taken one hospital 64 years to accumulate the same power to answer that question. But here's the kicker. As proud as I am of that study, which ended up cutting on top of all known best practices, rates of MRSA and bloodstream infections in ICUs by nearly half, top of all the bundles. You know, while the one headline was what it did nominally, a second headline was accelerating to 18 months. But the third is really a missed opportunity. That answer probably existed in the collective experience of healthcare in terms of which strategy was best. And this is where I'm so proud of what Apollo's 24/7 CIA clinical intelligence engine is doing, providing patients with decision support, providing clinicians with decision support. Sir Liam talked about another aspect of hardwiring, and that's hardwiring capacity for resilience. In addition to clinical cognizance, we need to think about our information systems, providing a real-time understanding of our status of supplies and capabilities, not only in normal operations, but of course also in unusual operations when we're stressed by natural or man-made disasters, including climate threat. Let me turn to the second wiring, soft wiring. And Sir Liam, Dr. Sangeeta referred to this as well. This is the issue of patient engagement. Patients aren't just recipients of care. They have to be partners in care. And the term co-production is so tremendously important. I observed this with my own father in terms of trying to advocate for his safety in hospital, only to be rebuffed. All he wanted was the same thing the hospital wanted, was a good outcome. But while we think of this in technical terms, in his words, it would have been, help me, don't harm me, respect me. And so patient involvement isn't a nicety, it's an essential and should be part of the patient safety rights charter. An element of the soft wiring is health equity, and this is a worldwide opportunity. We know that we have high-risk populations. In the United States, Black and African Americans have over 300% greater maternal mortality than white women. Latina women have over 150% greater. We know that women categorically are underdiagnosed and undertreated for coronary artery disease. We have to be sure that we focus on remediating some of these inequities by actually placing emphasis on these areas. We have to softwire the relationships amongst teams. Sir Liam talked also about the teamwork that developed during the pandemic, and we should capture that COVID dividend, as was mentioned. And one of their soft wiring in times of crisis, it becomes evident, but it's in times not of crisis that we need to software the political engagement and establish relationships at community, regional, and national levels so that those relationships are in place at the interface between healthcare and public health. Point 3 is the rewiring. And this is really a new way of thinking about patient safety. We need to be able to learn from both the negative and positive experiences. We've been focusing for years on failure modes. But you know, the aviation metaphor can break down. It assumes an absolute linear causality. If a potassium vial looks like normal saline, remove the normal saline, flush, so that they're not next to each other. This is the basis of safety 1.1. But where the aviation metaphor breaks down is that when Dr. Reddy was flying from Chennai to Hyderabad, that plane was going to Hyderabad. It wasn't going to Delhi. It wasn't going to Dubai. When a patient comes into the ER and are taking off with chest pain, that plane could land at myocardial infarction. It could land at pulmonary embolism. It could land at pneumonia. It could land at gastritis. It could land at a dissecting aneurysm. And so the complement to safety 1.0, the forcing function, and the linear relationship is to really an appreciation for complex adaptive systems and asking why it is that things in complex systems work and trying to distill those nuggets. So safety 3.0 is really the combination of both. And so the final wire that I'd like to address is the hot wire. And that's really a focus on sustainable healthcare. If healthcare internationally for a country, it would be the 5th most polluting nation. And the United States has to, embarrassingly, but responsibly own more of that. Our state in that country of healthcare pollution is 27%. Across contemporary healthcare, in most countries, healthcare produces 7 to 9% of the greenhouse gases. Hospitals are 2 to 5 times more energy intensive than office buildings, and ORs are more polluting than heavy industry. And we know that the most socially vulnerable are the most medically vulnerable, and thus the most vulnerable to the effects of climate change. They simply can't buy their way out. They can't compensate. We know that in cities like Delhi, like New York, like Washington, like Los Angeles, there are heat islands of concrete where the temperature can be 10 degrees Celsius hotter than other areas. And so I know the time is short, so let me summarize. We need to hardwire and use technology to aid reliability and decision-making and discovery. We need to softwire and engage the patient as an advocate and co-producer in their own care. We need to rewire our approach to safety from exclusively focused on causality to a complexity model. And we need to hotwire. Climate change is not just a moral or ecological issue, it's an issue of health and health equity. And in fact, when I sign off, I'll be going back to announce a new Joint Commission program on sustainable healthcare, a new certification at our meeting here at the National Academy's Action Collaborative. Thank you again for the opportunity to participate in this extraordinary conclave. And thank you for your leadership. Namaste.
Thank you. Thank you so much, Dr. Perlin. Very insightful, a very different approach. Thank you for finding time. And hopefully we might come back to you with a question or two. Now from the US, we're going to move to India, and over to you, Atul. Dr. Atul Kochhar, please. Well, I guess we're having a glitch there. So we move on from the US to Geneva. Neelam, if you could come in, please.
Sure. Thank you so much, Anupam and Sangeeta and colleagues. Really appreciate this opportunity to join you today. And I must congratulate you, Anupam, for spearheading huge momentum for patient safety and being a global patient safety advocate and providing excellent support for our global initiatives on patient safety. Now, you would all agree with me that stars have been truly aligned for patient safety over the last couple of years. We've seen unprecedented momentum at political level for patient safety through the Global Ministerial Summits on Patient Safety since 2016, and which led to a landmark resolution in 2019. Patient safety was identified as a global health priority. That resolution also led to establishment of World Patient Safety Day and the foundation for the Global Patient Safety Action Plan as a roadmap for the next 10 years. And I would say if in context of this topic of hardwiring, which is really interesting, what does it actually mean at the global level, for example? So I'm trying to put here patient safety is in the fabric of health system at the global level, and also at national level and organization level, and through partners' lens as well. So I would say it's moving from initiatives and projects to the way of life, to do it right the first time, from champions and movers and shakers to everyone, all stakeholders, their ownership. And when patient safety is mainstreamed and patient safety is institutionalized, then we will say it's been hardwired. Safety is safety first, and safety is non-negotiable. And I would say all these mechanisms which we have now been able to establish over the last couple of years at the global level, we have taken steps to hardwire patient safety through policy development at global level, through the establishment of World Patient Safety Day and the action plan, more importantly, I would say the reporting requirements which we have to the World Health Assembly, that every 2 years we report to the World Health Assembly how we are progressing in the implementation of the Global Patient Safety Action Plan and what achievements they are globally. In addition, as you are aware, last week we had a WHO global conference on engaging patients for patient safety to commemorate World Patient Safety Day of this year. And it was a great platform to have different stakeholders presenting their initiatives from across the world. And we also tabled a draft patient safety rights charter, as John mentioned. And that, I think, once we have going ahead and recognizing patient safety as a human right, this is also going to be extremely important in hardwiring patient safety at global policy level. Now, how do we translate this global structures and agreements and resolutions at national, subnational level? And I think definitely we need to build the case to take the implementation forward. We have to build the case based on local and national data and sharing of patient stories from heart. And that's what was really remarkable when we had patients, safety advocates and patients and families who've been harmed in healthcare demanding for safer care and sharing their experiences of unsafe care, but also how they brought about change in improvements in patient safety. So I would say at national and subnational level, patient safety in all health policies, in all hospital policies, in all primary healthcare policies, in all HR policies, in all policies for clinical and health programs, such as maternal health, HIV, tuberculosis, malaria programs, or safety programs, such as blood safety, injection safety, immunization safety, medication safety. So across the board, safety programs, clinical programs, and health programs, patient safety to be embedded in these programs and these policies. And that would really hardwire and provide sustainability. So we have to also look into that policies are just not documents, but they are fully supported by legislation. They have their budget allocations, as well as their full, how these budgets are going to be financed. And very importantly, a specific unit in the Ministry of Health at national level or a subnational level, which is responsible for overseeing and supporting the implementation of the action plan. In addition, I can share with you some countries which have established national patient safety centers, which are really these centers providing spearheading this improvement in patient safety across the country. Patient safety resolution particularly asks countries to integrate and implement patient safety strategies in all clinical programs and risk areas so that we can prevent avoidable harm primarily related to healthcare procedures, products, and devices. So I would say that there is a very concrete action to be taken at national, subnational level, which would hardwire patient safety at those levels. Coming to organization level and point of care, and this again rhymes with what John mentioned, design for safety. So plan change with all stakeholders and ownership and apply human factors in actually delivery of care. I would say the most powerful lever at the organization level is the leadership, the safety culture, openness and transparency, breaking hierarchical barriers, and truly providing a patient-centered care will really go a long way in hardwiring patient safety at organization level. Learning from high reliability systems and how do we actually make these as a way of life, not as only small-time initiatives. I would say reporting on adverse events, particularly by health workers as well as patients, will also give us the insight into what went wrong and how do we build systems. Particularly 2020 World Patient Safety Day recognized the issues of health worker safety. So the entire area of health workers, their educated number, their competency, the skill development, their safety, and even developing future leaders for patient safety will go a long way in making sure that patient safety learnings and initiatives are just not person-driven, but they are system-driven, they're institution-driven. Standard protocols will provide a hardwiring. And again, not only technical and managerial skills, but soft skills, communication, how do we communicate? How do we work in teams? And emotional intelligence, how do we build these capacity building into the building capacity of health workforce? And finally, I would say mechanism for engaging patients and families, not left as ad hoc and as and when possible, but again, hardwired in the DNA of the system at the organization level and point of care, having, and particularly this is one of the indicators we have given to the member states around the world to report on how many hospitals and how many countries really have patient representatives on the governing boards, so that there is a platform for the voice of patients. And last, I would like to touch upon the role of partners and organization institutions and the networks for sharing and their role in hardwiring. Particularly, I would say when I say partners, I would definitely like to put patients and patient organizations first, because we are fully aware patients are not empowered to even prevent their own harm. And so, we have to highlight the stories of patient harm and how do we actually implement change at ground level through patient organizations. So at all levels, global, regional, national, subnational, local level, at all levels, we need to have engagement with patients and patient organizations so that patients can play the role as educators, as storytellers, as advocates, as well as partners. A very important role academic and research institutions can play in this by building capacity of health workforce and also identifying research topics for PhDs and MDs. How do we implement the research on patient safety as part of the heart fabric? Some of the standards which are developed by accreditation organizations and professional bodies, again, will go a long way in taking forward patient safety. Civil society and their embedding patient safety in the strategic plans of professional bodies and civil society organizations will make it a real institutionalized approach to patient safety. But finally, not really the last but or least, but it is really the most important partner, which was mentioned about Sangeeta as well. How do we actually bring the technology into it? How do we get the industry, which is working on digital technology and medical products, the innovation in medical products, the innovation in technology, how do we utilize that for hardwiring patient safety and having some sustainable solutions through digital technology? I would say finally that the more mechanisms we create, the more it is mainstreamed, the more we integrate explicitly, the more it becomes the way of life. That's not an afterthought or it's an add-on, but the more it is actually our day-to-day work, more it will be hardwired. So with that, I would like to thank you for your attention and really appreciate this opportunity, Anupam and Sangeeta. Thank you.
Thank you. Thank you so much, Neelam, and over to Kedar. And I know Kedar has to go off for another meeting. Actually, everybody's juggling meetings today. I think we just picked a time when everybody has multiple commitments. Over to you, Kedar.
Well, thank you so much, Anupam. It's a pleasure to be on this panel with such distinguished colleagues and friends like Dr. Neelam and Dr. Atul and Dr. John Perlin as well, and of course to be with you, Anupam and Dr. Sangeeta. Thank you very much for the opportunity to be here. I think we all recognize, and other my colleagues have already spoken about this, the notion that patient safety is a complex problem that is both technical in nature as well as social in nature. If we consider sepsis to be a safety challenge, which I believe it to be, my simple way of understanding patient safety is that it's the #1 cause of in-hospital death, the #1 cause of readmission, and the #1 cost, at least here in the United States, of hospital care costs, the #1 cost of hospitalization. So it's a lot. There's a lot of different ways of understanding the epidemiology of patient safety. Many of us have written about this. Many of us have commented about this. Many of us have thought about where it rates and how many people are injured every year. But the bottom line is it is the #1 cause of hospital death, readmission, and cost. As a complex social problem, you need a complementary socio-technical solution, and quality improvement and the work that all of you do every day is exactly that, a socio-technical solution that is person-centered. Critically, Dr. Sangeeta mentioned this and other speakers have as well, this idea that we need a people-centered approach. We need to pick the right problems to work on, consider the fact that everything operates as a system, and then learn together and rapidly in small, simple tests of change to actually find out what will work to improve safety at scale. My view is that there are 3 primary defects that we're trying to solve around safety. And just very briefly, I will say that they come down to recognition, knowing that there is an unsafe situation in place, reliability, ensuring that we actually take a system level approach, and then getting to scale. Every one of those, recognition, reliability, and scale, requires the engagement of patients. And so I can talk for a long time about the technical dimension of each of those. AI and technologies will almost surely help us on the recognition question of diagnostic challenges and failures that we have in medicine. There are very exciting data coming out of sepsis studies right now that help us understand whether a patient presenting to an emergency room is in fact suffering from some early signs of sepsis even before we might see it clinically. But the bottom line is that I think that patients and families actually are our frontline recognition system. Technologies will help, don't get me wrong, but the people that are in our systems, the people that are with our patients every day, all day, 24/7, those are the people that will help us to recognize the challenge in our patients sooner and faster than any technology can possibly recognize at this time. So we have to find a way to listen more effectively to our patients, to our families, to help us understand the risks that might be present. From a reliability perspective, today, unfortunately, at our front lines of care, we burden our front lines of care with new priorities every week or month. In my hospital in New York City, at New York Presbyterian, every week there's some new priority that's been handed to the front line as if it is something new and different that they're meant to solve, whether it's an equity problem or a safety problem or a cost problem, or indeed a decarbonization problem, John. Whatever the issues are that the system is paying attention to, we seem to treat those as if they are separate work streams, when in fact it is the same frontline care team members that are responsible for all of them. And what we need to do, instead of bombarding our front lines with separate problems, is to think about how to give that frontline team a reliable operating system capable of building towards better quality, safety, value, and indeed some of the other objectives that our systems might possess. That type of operating system, when installed in the system, is capable of achieving not only results, but results at scale across multiple priorities that our system faces. And then the last point I'll make is true scale. Again, here I'll say that without the engagement and involvement of patients, we will not succeed at getting to true scale. We do need learning systems that are capable of allowing our systems to talk with each other. I remember during the pandemic having a conversation with Dr. Sabal, with you, about the learning system that Apollo had created for spreading COVID information across your many institutions across the country. That kind of rapid learning system is not simply relevant, or not only relevant for a pandemic infection, it's relevant every day across every clinical condition that our patients encounter. We need that kind of rapid learning system throughout our enterprises and indeed across the world. So with that, I'll stop. I did 3 major problems: recognition, reliability, and scaling effectively to solve the massive socio-technical problem of safety. And to my mind, patients and the systems that we architect will help us to get there. So thank you, and I'll turn it back to you, Dr. Sabal.
Thank you. Thank you so much, Kedar. And over to you, Atul. Apologies for the technical glitch. Look forward to your comments, please. Atul.
Thank you so much, Anupam. Thank you so much for making me a part of this very distinguished panel. And I think my job is absolutely easy now, coming in after Sir Liam, Sangeeta Madam, Dr. Neelam, Dr. Perlin, and Dr. Kedar. It's been a wonderful session, right? And I could easily say ditto, 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 and get away with it, right? Or take Dr. Perlin's all the wires and then remove the barbed wires and the trip wires and be done with it, right? No, but patient safety is in the DNA, as Dr. Neelam Dhingra. We have to find ways to inculcate patient safety, institutionalize it, and bring all those basic tenets into our DNA, the collective consciousness. I would also like to mention that the easiest would be to go back to the basics. Let's take WHO's patient safety goals, take them to the far and wide nooks and corners of our wide country, and then start from bottoms up approach. Let's go to the last in the line, the poorest of the poor, our common patients. Let's go to a village level. We have 250,000, that's 250,000 villages, and villages are the absolute basic units of our country. And let's empower all those individuals, 1.4 billion citizens, and then empower and then start working bottoms up, speaking about all the basic patient safety goals. We could speak about the safe surgery, as basic as hand hygiene, as basic as the communication, and we have to learn to develop the ideal patient-provider partnership goals also, right? Develop that mutual trust, shared decision-making, transparent communication, and joint commitment to safety. We all know that, and use technology to do that. As everyone has highlighted, that technology is the only bridge which can help us bridge this wide gap between provider versus providee. So ultimately, it boils down to the nuts and bolts. So I think this has been a wonderful session. And just to summarize, let's empower our citizens to speak up, ask the right questions, and that's the be all and end all of it. If our patients are empowered, if our doctors know what to do, and let's start at the medical college level, where patient safety, despite the entire humongous syllabus, it still does not get about an hour of, amongst all those thousands of hours, it does not get 1 hour. So let's go back to that, and somehow build up on the basis of primum non nocere from the doctor's side. The communication is never taught. You are master of communication. I mean, you speak so well about all the basic tenets. So let's start to reinforce all the basic tenets of patient safety goals, which are very well enshrined in all our documents. Then we also realize, as Sir Liam very rightly said, that the COVID has all about giving us lessons. Besides resilience, of course, that's been a one lesson which has been there, but it's also been about telling us that we cannot get away by creating islands of excellence. If we are to improve the global health, we have to start thinking about we are as strong as the weakest link in the chain, right? That's a cliche. But if we are to improve the global immunity, we have to start thinking about herd immunity or herd quality, if I can coin that. So let's go back to the drawing board, reinforce the basics, have a very, very strong foundation globally, have a bottoms-up approach, and I'll again say that with due regards to Dr. Perlin, all those wires he mentioned, they're so important. They are the basic tenets, and Dr. Neelam, Sangeeta Madam, Dr. Kedar, I think everything is in there. Everything is in there. We just have to keep up that spirit of sharing and collaboration, the spark of which we saw so brightly during the COVID. Let those free grand rounds continue. Let the spirit continue, and let's all of us come together as a global village. And these seminars and your IPSC, it's certainly a help. I mean, those wonderful meets, the sharing of ideas, the sharing of thoughts. That's what it's all about, right? And that's a huge, huge major step towards institutionalizing patient safety, as Dr. Neelam very rightly pointed out. So let's get patient safety in the DNA of not only the service providers, the doctors, or the healthcare providers, but into the common man. Let them demand patient safety, and let us all come together to give it. That's my two bit about it. Thank you so much.
Thank you. Thank you so much, Atul. And you know, in the interest of time, I'm just going to ask one question each to all of you, and it's going to be the same question. And the question is, what should I, as a healthcare professional, do tomorrow that I wasn't doing today? John, Neelam, Kedar, and Atul. That one thing that I must do today, and sort of commit to that. Unmute yourself.
Dr. Sibal?
Yeah, can hear you. Yeah.
Dr. Sibal, one thing is to commit to patient safety. Is that I know we think of safety as a background quality, environmental quality, but it's not a background quality. It's a proactive requirement. And so as we think about, you know, in our roles as frontline clinicians, as we go into a patient's room, as we see a patient in clinic, as we go to a patient's home, I think we have to be proactive in thinking about what needs to go right and how can we avoid certain things going wrong. We talked in very technical terms about safety, but it's got to be top of mind, not a background quality. And so I would say whether we're administrators and administrative leaders or frontline clinicians, is that we commit to making this a top of mind activity. Thanks.
Thank you. Thank you so much, John. Neelam? The one thing.
Thank you. So actually, there are going to be two things, not one, because they go hand in hand. Since the beginning of the year, we started preparing for World Patient Safety Day theme and the activities around it. And so the preparation was going on for September, but in February, we had an extremely impressive and participatory ministerial summit where we had more than 80 head of states who attended. And in all the statements during the summit, every country spoke about their commitment to Global Patient Safety Action Plan. Similarly, for World Patient Safety Day, we have such phenomenal engagement and ownership from member states around the world. So wearing my global hat, my one thing or the two things would be build onto this global momentum and actually ask every country to prioritize patient safety through different mechanisms of WHO. So we reach out to countries and ministries of health to prioritize patient safety and also build on to the lessons we have learned from implementation over the last 2 years and take it forward so that we can show significant improvement over the next 2 years. We are supposed to report to the Assembly in 2025. So incremental improvements and also transformative improvements. And as WHO, we are going to capture all those improvements and success stories and share with the rest of the world. So I'm committed to make that impact at global level. Thank you so much.
Thank you. Thank you so much, Neelam. And over to you, Atul.
One thing, Anupam, would be to empower the patients, empower our colleagues, empower our nursing officers, empower everyone around us to speak up. In the interest of seniority, many times you've seen that people don't speak up and engage patients and probably listen more. I mean, in these hard-pressed time, and time is a very precious commodity, all doctors, all healthcare providers, I mean, there's so much of stress actually. So let them listen more, engage patients better. So that's one thing, besides all the other things which are on the side.
Thank you. Thank you so much. This has been an absolutely fascinating session. Big thanks to Sir Liam, Dr. Sangeeta Reddy, to Dr. Perlin, Dr. Kedar Mate, Dr. Neelam, Dr. Atul, my colleagues Gaurav and Yogmaya, who've worked tirelessly to get all of us together. And I'm going to hand it over to you, Gaurav, to bring this to a close.
Thank you very much, sir, and to our eminent panelists for their insightful and stimulating discussion. You've definitely shared very valuable lessons and best practices on patient safety into the healthcare system. We'd like to thank our audience for the active participation, and we hope you found these sessions useful and interesting. Before we conclude, I would like to announce the next virtual Transforming Healthcare IT conference on 15th of October at 6 p.m. We really have another set of really great and eminent panelists there and the moderators for that session. So please mark this on your calendars and join the conference on 15th of October. I'm also proud to see all of us coming together for such a noble cause. Thank you, all of you, for joining us today. We hope you had a good time. Please share your feedback with us through the link on your screen or scan the QR code, and we would also share this feedback on your emails post this conference. We'll very soon announce dates for our 11th International Health Dialogue in February 2024. Please stay in touch with our website and application. Have a very wonderful evening. This is Gaurav Loria signing off. Goodbye and take care.
Thank you, Gaurav. Thank you.
Bye. Bye.
Thank you. Thank you, everyone.
Thank you.